Welcome to the lecture on the hip joint. You're going to see a lot of similar things that we've talked about in the past. A lot of this is going to resemble the shoulder, but realize there are some significant differences between the hip joint and the shoulder. So first thing let's do is look at a few of these landmarks as a refresher. So A, head of the femur. I, greater trochanter. B, neck of the femur. C, lesser trochanter. Now, D, let me skip down to E. E is the shaft. Now, if we look at D and J, D is considered the pectineal line. And as it continues to come down, you'll see that it turns into J, which is the linea aspera. So on some of our skeletons at the school, because they're plastic, the linea aspera can be a little bit difficult to detect. But on a real human skeleton, the pectineal line is a very rough, rigid surface. It doesn't stick up very far from the bone, but it is very rough. And it is strictly for muscle attachment. So there's a lot of large muscles that have some form of attachment to the pectineal line and the linea aspera. As we continue to move inferiorly, F is the adductor tubercle. If we look at G, G is the medial epicondyle, and H is the medial condyle. So if you remember back to the elbow joint, those condyles were given specific names. In the case of the knee, it is not. It's just called the medial condyle. If we look at K, K represents the lateral epicondyle, and L is the lateral condyle. So let's get some of your lecture notes filled in. So how do we describe the hip joint? Well, it's synovial, just like the majority of the joints that we've talked about in the human body. Is it mobile, stable, or a combination of both? So, like I said, there's some similarities to the shoulder joint, but there are some significant differences. So it's a great combination of stable and mobile. It has less mobility than the shoulder, but greater mobility than other joints. But it has a lot greater stability compared to the shoulder. And the reason is it's a large joint in comparison to the shoulder. The socket is deeper, the head of the femur is much larger. There's a lot of strong ligaments that reinforce the joint capsule, and a large amount of very big muscles that are there to assist in supporting the joint also. So just like the shoulder, we can describe it as synovial, ball and socket, triaxial, or multiaxial, whichever term you prefer to use. Now, if we look at the motions, again, being a triplanar joint, we're going to have the sagittal plane, flexion and extension. And most people have a grand total of about 120 degrees of motion from extension all the way to full flexion. If the next motion is the frontal plane, AB and AD duction, and most people have somewhere in the neighborhood of about 60 degrees. And then internal, external rotation, there's approximately 40 degrees, which is about half of what people have in the shoulder. So you can see the ranges are less, the range of motion, the number of degrees, is smaller than the shoulder. But again, 3 planes of motion. So we also need to do a review on the bony landmarks of the pelvic portion of the hip joint. So I'm looking on page 299 in the textbook. Realize that the image that you're seeing on your screen right now is slightly different angle-wise as far as what's in the textbook. So it's going to be backwards. Keep that in mind as you're studying. So starting at the top, D is the iliac crest. E, anterior superior iliac spine, or ASIS. F, anterior inferior iliac spine, AIIS. From there, if we move to the letter R, that is the posterior superior iliac spine, or PSIS. Q is the posterior inferior iliac spine, PIIS. P, that is the greater sciatic notch. Let's look at the letter O. O is the ischial spine. N, lesser sciatic notch. M is pointing to the ischial body. L is the ischial tuberosity. So your sits bones or your butt bones, you know, if you sit on a hard bleacher bench too hard and after a while your butt starts to hurt, that's because of the pressure that's being transmitted from the surface you're sitting on through your muscles onto that ischial tuberosity. K is pointing to the ischial ramus. Now the word ramus means bridge. Looking at letter H, that is the superior pubic ramus. I is the body of the pubic bone, or pubic body. And then J is the inferior pubic ramus. So next week in lab, I'll break these out and I'll actually show you individually what these look like. There's not a magical line that differentiates between the rami and the next rami. But once I show you, you'll get a good idea of how that exists. All right, and the last part of this structure I want to talk about is the, and I've heard it pronounced a couple of different ways, acetabellum, acetabulum. Anyway, it's the socket portion of the joint. So look at G. G is pointing to the pubic portion of the bone that contributes to the socket. Moving superiorly, the kind of medium gray there, that is the ilium portion that contributes to the socket. And then the darker gray is the ischial portion of the socket. So the socket is made up of all 3 bones. Approximately 1/3 of each bone contributes to that. Okay, moving right along with the lecture notes, let's go to the joint structures. Well, we have a capsule. Again, it's a synovial joint. So we know there's a dense connective tissue outer layer, and then the intersynovial membrane with fluid. This capsule is very strong. The labrum So we've seen this term before from the shoulder. So remember that the labrum is fibrocartilage. It adds to the depth of the socket. Even though the socket of the hip is deep, it still assists in making it a little bit deeper and acts as a shock absorber. The labrum of the shoulder, the labrum of the hip can be injured and have tears in them. Now, if we look at our ligaments, we have iliofemoral, pubofemoral, ischiofemoral, ligamentum teres, capitis, inguinal ligament, and IT band. So, looking at this image, A is the iliofemoral ligament, and the function of the iliofemoral ligament is to support the anterior portion of the capsule. B is the pubofemoral ligament, and its function is to limit hyperextension of the hip. If we look at the letter C, that is the ischiofemoral ligament, and its function is to limit hyperextension and medial rotation. A little bit of an odd ligament. How can a posterior ligament limit hyperextension rather than flexion? Well, it's because of where the ligament originates, where it inserts. And if you look at the direction of the fibers, you would see that as you came into flexion, the ligament itself would kind of unwind or assume a shortened position. So in this case, it's an odd one that it does limit hyperextension. The next two ligaments, the ligamentum teres, ligamentum capitis, they are intracapsular. It means they're inside the capsule. They attach the head of the femur to the acetabellum. They really don't provide any support for the joint itself. The current thought process behind those ligaments is they provide stability for blood vessels, arteries, etc. The next ligament is the inguinal ligament. It does not provide stability for the hip joint, as it runs from the ASIS to the pubic tubercle, and it's more of a dividing line. Separates the abdominal cavity from the thigh itself, so it's more of a landmark than anything. Next is the IT band, and it is a tendinous, a sheet of tendon that connects the tibia to the tensor fascia latae muscle, TFL. If you ever rub the side of your thigh real hard, sometimes you'll feel that it's a little painful. That's a tight IT band. So learn your muscles in groups. Hip flexors. What's the nerve? I don't know. Femoral. Oh wait, there's one exception. Memorize the one exception. Next group, the adductors. What's the nerve? Well, obturator. Oh wait, except there are two exceptions. Kind of look at it close, you'll see it. And last, hip extensor group. What's the nerve? I don't know, sciatic nerve? Oh wait, there's one exception. Take a look at it. Make sure you know the exception. Okay, make sure you watch 17 and 18 lecture notes or videos. Come to Tuesday's lecture next week with questions, please. Have a good afternoon.